Next, we have medullary carcinoma of the thyroid, which classically will present as an asymptomatic thyroid nodule. This also tends to have a good prognosis. The pathophysiology of the medullary carcinoma of the thyroid can be sporadic in nature. However, this is related to the RET proto-oncogene, which is ultimately what gives rise to the multiple endocrine neoplasia, or MEN syndromes. More on this in the coming slides. Therefore, in patients with suspected medullary carcinoma of the thyroid, the family history is going to be essential, as we may see evidence in their family history of one of these MEN syndromes. One of the keys to the diagnosis of medullary carcinoma of the thyroid, especially on examinations, is that these patients are going to have the presence of calcitonin-producing C cells. Generally speaking, these patients are going to have normal levels of calcium when you actually measure their serum calcium level. However, if you obtain a serum calcitonin, this will classically be elevated in patients with medullary carcinoma of the thyroid, and this is extremely high yield for examination purposes. Additionally, this calcitonin will come in handy later after we resect the tumor via total thyroidectomy and lymph node dissection. We can then follow the level of this calcitonin, which was previously elevated, and watch as it hopefully drops and stays low over time once the patient is in remission. In addition to calcitonin, we can also follow CEA, also known as carcinoembryonic antigen. But really the highest yield takeaway from this medullary carcinoma of the thyroid is its relationship to the multiple endocrine neoplasia syndromes via the RET proto-oncogene, as well as the fact that these patients classically will have an elevated level of calcitonin. Just to briefly review here our MEN syndromes. In MEN 2A, our classic features are going to include pheochromocytomas, medullary carcinoma of the thyroid, as well as parathyroid hyperplasia, whereas in MEN 2B, we may see pheochromocytomas as well as medullary carcinoma of the thyroid, but these patients characteristically may also have oral or intestinal neuromas, as well as a marfanoid habitus, in which they have some of the physical exam features of Marfan syndrome, such as elongated limbs and tall stature.